We might get started. I think people will drift in from afternoon tea because everything's sort of been running a little bit over today. We're going to have a Q&A at the end. So we'll have the talks. Please keep your questions. There's some microphones in the audience. So this session is hopefully going to shed some light on some minor corneal procedures for the general ophthalmologist. And I have the pleasure of introducing Dr. Tanya Trin from the Sydney Eye Hospital. She's a specialist in corneal disease, and she'll be talking about corneal foreign bodies.
Okay, so corneal foreign bodies and rust rings, the bane of our existence. Removal of corneal foreign bodies and rust rings, it's the second most common form of ocular trauma, with abrasions being number one. But major morbidity from vision loss is not a huge component of this entity, and nor should it be. Most of them are going to be superficial and benign, and there is a strong focus at the initial outset of making sure that we've excluded a perforating injury and making an emphasis on protective eyewear as we move on. Okay, so in various studies we'll report different prevalence of corneal foreign bodies or conjunctival-based foreign bodies, but about a Swedish study puts this as high as about 8.1 per 1,000 cases, and 40% of those, in terms of ocular injuries, are ones that have lodged in the cornea or the conjunctiva. So in terms of history and presentation, it's usually a sudden onset event, although a significant proportion of your patients will probably show up 2 or 3 days later, not really having a history of high-risk activity, but not really noticing that an injury occurred at the time. Sometimes they can be wearing eye protection, but they've actually turned their face at a particular angle and they've not got the nice wraparound ones that would be protecting them from the eye. They have persistent pain and discomfort in terms of decreased vision. Usually it's pretty intact, but they perceive that the vision is decreased, depending obviously on the severity of the injury. As I said before, they have a history of high-risk activity. Pain localization in these patients is quite inaccurate. And usually when they present after 24 hours of being quite irritated, you'll see quite an element of iritis, injection photophobia, wateriness, and pain. It's really important always to avert the lids and make sure that you've swept underneath with some anesthetic, just to make sure there's nothing lodged under the top, particularly if you're dealing with a blast type situation, and look for Seidels positivity on your slit lamp examination. And then other more sinister signs to suggest that your foreign body has penetrated deeper into the eye, like your cataract, peaked pupil, ACEA reaction, poor vital signs of the eye, and transillumination defects. So it's really important that you're considering and ruling out a perforating injury, and include some imaging if needed. So types of foreign bodies, we'll cover mostly in this talk the metallic rust rings, because they're the most challenging to remove. You can get a reactive iritis if it's been there present for more than 24 hours, and can lead to significant pain and perception or vision loss. And they are at risk for secondary infection or keratitis. Organic matter can also be an issue, with a high risk of infectious keratitis and a higher risk proportionately of fungal involvement. And inert substances such as glass still requires removal from the pain aspect, but tend to be less immunogenic. And there's just a schematic diagram of the inflammatory process that's kick-started when a corneal foreign body gets lodged into the surface of the eye, but you get the immediate and the delayed reaction. And commonly the delayed ones are ones you have to look at a little bit more closely to make sure that we're not dealing with anything in the eye. So approach to the removal of the foreign body or rust ring, the vast majority of these, after you've excluded perforation, can be removed with simple irrigation and cotton swab, but usually by the time they get to you guys, someone has already tried that. The technique that I usually use is having a curved needle bevel facing towards me under slit lamp guidance. And a corneal burr is used in some people's hands, but I would not advocate that. I've had 2 cases where corneal burrs have caused full thickness perforations. So in terms of helpful tips for needle technique, if you can get to them within the first 24 hours, they usually flick off in one go, and they haven't had a chance for the rust to sort of help break it up into tiny little pieces. But unfortunately, a lot of them will present late to you, say, for example, after the weekend where they've been doing home jobs and they come and see you on a Monday. And when they become more embedded, they can become more difficult to sort of carve out. I try to bend the needle, and I've got an image of that coming up. We use a 25 to 30 gauge needle with the bend of the bevel towards you, 90 degrees to the bending at 90 degrees to the bevel and then using that tangential to the surface. It's really important, obviously, to anesthetize the eye. You can use a drop of betadine, although I don't always, but stabilization of the arm and elbow is really important, particularly if you've got a short sort of arm like I do. Hovering is not your best friend here. If the chunk is really difficult to dislodge, often I will slather, after I've excluded everything else, I will slather them in a fair amount of Chlorsic ointment and put a patch on for 24 hours and get the patient to come back. And there is a little bit of a lytic reaction that happens around the rust ring, which often allows you to scoop it out in one go, and sometimes even with a cotton tip the next day. So that is quite handy for rust rings that are quite challenging, because you often pick at them and they break up into little tiny pieces, and then you find that you're picking away and trying to get you haven't got that much handy to scoop it out with. So in terms of bending the needle, I would usually use something equivalent to a mosquito forceps if possible, just to bend that bevel towards you, and then you can just see that nook or the angle of the needle there. So what is your end point? Because that's probably the most common question that you'd sit back and ask yourself after digging for a fair amount of time. So ideally, you shouldn't see any particulate matter in the bottom of the rust ring. They are dark brown pieces. If it's been there for a little while, you will get some staining of the surrounding stromal tissue, and some of that staining is okay if it's sort of like that light yellow color, but if you're seeing actual flecks of material, that does need to be removed. And sometimes you will need several attempts, so don't beat yourself up if you're not getting this all in the one go. So in terms of removal of a foreign body, this is one that has been there, a fairly fresh injury same day. And if you can see when we're coming in with the bent needle process here, as we're moving this and just touching it gently, it all slides out all in one go. And you can see that the underlying stroma on the other side is actually quite clear, because it hasn't had a chance to form that sort of lytic reaction at the level of the stroma. I just put this video in here to demonstrate what the concept of the burr is and why I don't use it. The concept of using the burr is because it wants to flick out the foreign body and they want to shave down the rust ring, but it is really aggressive. And if you're looking at the rust ring here, this is one situated at the limbus. It's been there a little bit of time because you can see that light ring around the rust ring. The bulk of the rust ring, or the center of it, is gone already. I don't know if we can fast forward this a little bit here. But in comes your burr at some point. Any time now. But you'll see the point I'm trying to demonstrate here once it comes into view is that the burr digs out quite a lot of tissue quite rapidly. So control of the situation is really difficult. I'm just seeing if it comes out. Not only that, so here comes the burr, if you can see it. The head is almost as big as the wound itself. It's rotating quite rapidly, and you can see that it eats away at the tissue very quickly, and you've got patient movement on top of that. So this is the reason why I don't like to use the corneal burr. It can cause stromal damage, can lead to perforation, infection, and also astigmatism. And you do need to use dedicated corneal ones, not the dental ones that I've had one case use before. Most corneal rust rings should not have an impact on vision, as I made reference to in my first point. So really, they should have an excellent visual prognosis, even if the foreign body ends up centrally, if you're able to do a pretty good job of cleaning it. So make sure that you do make every effort to remove them as thoroughly as possible. Just going back, so which ones to refer to your friendly corneal ophthalmologist? So if it's not improving, if they've got persistent pain, worsening vision, worsening injection, make sure you look again. If you're pretty sure you've excluded any perforating injury, but they've still got problems, make sure that you're gonioing them and making sure you're looking at a really well-dilated fundal examination, looking at the state of their lens, or any transillumination defects in their iris. If it's evolving, so if you're looking at evolving infiltrate, if they've got a significant amount of AC inflammation and cataract formation, then you want to make sure that you're considering other entities. And if they've got a complicated cornea, so eyes that have had any LASIK or a Lalex type procedure, neurotrophic corneas in particular that aren't healing well, or patients with a corneal transplant. Thank you very much.
Thank you, Tanya. I now have the pleasure of introducing Associate Professor Shameen Samwik-Rama. He's a corneal and cataract expert and an NHMRC investigator grant holder, which is impressive, and he's working at the Westmead Hospital. Today he's going to talk on superficial keratectomy.
Thanks, Stephanie. So what I thought I'd talk about today is really what is a superficial keratectomy, what are the indications, the different techniques you can use to achieve your superficial keratectomy and what can go wrong. In a nutshell, superficial keratectomy is the manual dissection of the superficial or anterior layers of the cornea. It can be just the epithelium, which is image A, epithelium and basement membrane, which is B, epithelium, basement and Bowman's, C, and then finally a little bit of anterior stroma as well. For the purpose of this talk, I'm just going to focus on the first three, and mainly the first two, because I think that's more in the realms of a comprehensive ophthalmologist. Certainly when you're doing anterior stromal dissections, it's different techniques, there's a lot more challenges to it. And I'd probably say that's more where your corneal subspecialist would be more comfortable to work in that space. When you think about the indications, a lot of the textbooks and papers break it down into common versus uncommon pathologies. I mean, the commonest time that any of us would have to do a superficial keratectomy is actually when we do pterygium surgery. And the textbooks describe pterygium as sitting above Bowman's, which is why you can remove it relatively easily. And that's true for the majority of the time, but certainly sometimes pterygiums can invade Bowman's, and they're the ones where it's really difficult to get that smooth surface. So that's when you're doing the type C, where you're removing Bowman's as well. Beyond that, Salzmann's nodules are very common, and we do a lot of that. Band keratopathy is also very common, as well as recurrent erosions. And less common, you get the degenerations and the dystrophies. I want to draw your attention to peripheral hypertrophic subepithelial corneal degeneration, which didn't exist when I was training. It's a new diagnosis that's been about for maybe 5-7 years or so, and I'll show you some pictures. On the rare side, you start looking at stuff like keratitis, limbal stem cell failure, and in these cases, you're more likely to do that sharp dissection. So for example, in a keratitis in a non-healing eye surface, you might need to remove some of the necrotic tissue to allow it to heal, and that's where that sharp dissection comes through. But rather than thinking about it in terms of common versus uncommon, I'll actually advocate that you think of it in terms of nodular versus diffuse. And the reason I say that is the techniques are different, the indications for treatment are different as well. With nodular corneal changes, you often find that the symptoms is discomfort because it's lumpy, and so every time they blink, their eyelid traverses over that, and it's uncomfortable. Secondly, they tend to be peripheral, so they can induce astigmatism. So you'll find that people come to you because of blurred vision. And the third common time that you would encounter it is, say you're planning cataract surgery and the Ks are a little bit abnormal. It's worth removing these, or doing a superficial keratectomy, removing, for example, the Salzmann's nodule, waiting, I'd say 3 months, let everything settle down, and then doing the cataract surgery at that stage. You get a much better outcome. In terms of diffuse, it's slightly different. In band keratopathy, recurrent erosions, and the dystrophies, you find that it starts in the periphery, goes central, and the commonest time people actually come to you is in the context of band, if it's poor vision, in the context of the dystrophies and the recurrent erosion because of pain. But that discomfort from that lumpy feeling is not there. So, just checking time. In terms of common things, the Salzmann's nodule, very, very common. We've all seen it. It's mostly idiopathic, but there's a variety of other things that can cause it. And of note, there's an absent or disrupted basement membrane. So often you have to make sure you get under it. The technique I'll show you, it's a very straightforward technique. And the thing to note is it can recur. This is that new thing, the peripheral hypertrophic subepithelial corneal degeneration. It's an unknown etiology. We don't really know why it happens, but we do know it happens to women more than men, Caucasians more than other ethnicities, and it typically starts in that 50s age group and then gets worse as you get older. And it's bilateral, gradually progressing, almost circumferential perilimbal changes, and it's a nodule. It basically looks like multiple Salzmann's nodule strung together. Of note, there's no inflammation. So it's something that patients will say, no, I've never had a red eye or anything like that, but they're getting this and it's bilateral. And generally speaking, you can peel this off easily. They can recur, but they recur quite late. And if you need to, you can peel it off again as required. In terms of the diffuse, band K is the most common. It's calcium deposition. We all know this. I say it's worth, you find it idiopathically in terms of local inflammation, for example, chronic uveitis, glaucoma, but also for systemic diseases such as renal dysfunction, parathyroid disease, so anywhere there's the calcium phosphate imbalance. And the best way of tackling this is to use EDTA to chelate it, which draws out the calcium from the cornea and gets rid of it. And finally, epithelial basement membrane dystrophy, which can give you recurrent erosions or recurrent erosions itself. It's in epithelial basement membrane, you get duplication and thickening of that basement membrane. And so certainly, especially if there's a lot of this duplication in the central visual axis, a superficial keratectomy can improve vision. And in the context of recurrent erosions, it improves their comfort. So in terms of technique, really there's two techniques. In the nodular technique, or for the nodular changes, you often find that there's a plane that you can get under. This video is courtesy of Elsie Chan, and you can see here that what she did was she roughened the surface to get to that plane. And just with a 0.12, you're able to elevate it and peel it off quite nicely. Occasionally, you have to use a crescent blade tip down to propagate the dissection and maintaining it. Very rarely you have to do a sharp dissection. That sharp dissection has risks, the main one being that you can elevate some anterior stroma and get an uneven surface. So if you can, use a more blunt dissection where you're pushing it along and try and avoid the sharp dissection where possible. With diffuse, it's a slightly different technique. This is epithelial basement membrane dystrophy with quite a few whorls in the central zone. You're using long pulls on the cornea, or pushes, so your strokes are long to try and minimize the rake lines you can get. And it's often you can use alcohol, so 30% alcohol for 30 seconds using a corneal well, which will help loosen the epithelium. And one of the things, and you'll see there's a tiny bit of replicated epithelial basement membrane right here where I'm working on, where it does take a few strokes to get rid of that basement membrane. And you can just use your crescent blade. If you want, you can use a diamond burr to polish it very gently. In the context of band keratopathy, EDTA, if there's calcium in the anterior stroma, will help draw that out as well and get improved visual outcomes. In terms of post-op care, all these patients should get a contact lens just for comfort. And what I tend to do is just give an antibiotic and a steroid. Antibiotic for, obviously, to stop an infection, steroid to decrease inflammation. It is painful, so you have to warn these patients that it's quite sore. I give Panadine Fort, and I also give Phenergan, because 2 tablets of Phenergan will mean that they get a good night's sleep, and they're appreciative of that. After day 1, I see them at 1 week, and I take that contact lens off, and in the vast majority, the epithelium's healed at that stage. But if not, just a bit of Chlorsigg ointment. I don't put a new contact lens. I just use Chlorsigg, finds that fixes it up. Once the epithelium's healed, I stop the antibiotics and just continue the steroids for a month. There are some risks, but fortunately it's very rare. Intraoperatively, you're talking about rake lines and scar and elevating so rake lines are scratches on the surface and elevation of the anterior stroma, particularly if you're doing a sharp dissection. So try and minimize that. Postoperatively, keratitis can happen, though uncommon. Non-healing epithelial defects, such as the image down below, which can cause haze and melt. So you've just got to be careful in your patient selection that you're not doing it on someone who's neurotrophic, for example. And obviously there's a recurrence of pathology that can happen. So in summary, this is a relatively common procedure that we use. The evidence from outcomes are quite good, and I would commend this article, which is a very nice summary of it. But basically, you're looking at 70 to 100% for the variety of pathologies we encounter. The techniques you use will vary, broadly speaking, divided into nodular versus diffuse, and it's generally very safe and easy to perform. Thank you very much.
Thank you. That was an excellent summary. I'd now like to introduce Dr. Nick Tolster, who's a corneal and glaucoma expert at the Royal Brisbane Hospital, and he's going to fill us in further on EDTA chelation. Take it away, Nick.
Thanks very much. Thankfully, Shamin's given us a little bit of an intro into what I'm going to be talking about. EDTA chelation, I think, is eminently accessible to the general ophthalmologist. It tends to be one of these things that's thought of that has to be sent along to the corneal specialist, but by no means is that the case. We all know what band keratopathy is, and we've seen it. It's a slowly progressive deposition of calcium in the hydroxyapatite form, and it tends to start in the peripheral cornea, often just in from the limbus with that little lucid zone between, and then progresses across into the visual axis and predominantly in the interpalpebral zone. And so that sort of classic appearance is familiar to all of us. I hate to put up histology slides. Svetlana will be speaking in a moment. She's happy I have. But there are reasons to know about the histopathology, and that relates to how treatable it is. The image here you can see shows deposition of calcium in the Bowman's layer superficially, but there's also some deposition of calcium in the deeper stromal layers, the anterior stroma, and that relates to how easy it is to get rid of that calcium later on when you're there, and as I show you later on, worrying away at the cornea for 15, 20, sometimes 30 minutes. That's because of those deeper, more ingrained deposits. So it's worthwhile knowing that that is there. And obviously you can get varying severities of band keratopathy, some of which are just mild superficial haze, and some of them which form crusty, flaky, nasty ocular surfaces which are painful for the patient but also break down and create epithelial defects which increase the risk of keratitis and severe vision loss. So why does it occur? Well, for the most part, it's going to be ocular causes, and these are often eyes that are pro-inflammatory for whatever reason, whether that's uveitis or some other anterior segment inflammatory disorder, keratopathy, dystrophies, but also very sick eyes that are at the end of their life, like icicle eyes. Things that we put inside the eye, like silicone oil, and some of the topical medications that we use, which increase or dysregulate the balance between calcium and phosphate that promotes deposition of these deposits in the cornea. And lastly, but not least, exposure. So that's why it occurs within the interpalpebral zone, particularly because we're getting drying and therefore concentration of that calcium and phosphate. But then conditions that enhance that drying and exposure, such as keratin conjunctivitis sicca, Sjögren's disease, poor blink and exposure. So those will be very familiar to the ophthalmologists in the room, but then this sort of elephant in the room, what about the non-ophthalmic causes, and do we need to worry about those? And I'll speak to that as well. Clearly there are a number of causes, but generally I break them down into things that cause reabsorption of calcium from bone and therefore increase our circulating calcium or phosphate, things that cause us to absorb more calcium from our gut, and then things that decrease our ability to clear it renally. And lastly, unrelated to calcium are some things that chemically promote the deposition, so things like mercury fumes and a few other rarer exposures. So should we be doing systemic investigations for these patients? And I think if you can find a clear and obvious ophthalmic cause that you can put it down to, then no, you probably don't need to investigate these patients. But if you're not sure, if there's some reasonable suspicion that there may be something else going on, or if you can't find a clear ophthalmic cause, then it's reasonable to perform investigations to make sure they don't have some hypercalcemic state or some other serious condition that warrants treatment in and of its own regard. And so here's a list of the things, but the things I would just point out. So obviously full blood count, EUCs, serum calcium and phosphate, but also urinalysis and urine microscopy looking for casts. Investigations for sarcoid disease. I've had a chat to my respiratory colleagues recently. ACE testing is on the way out due to its poor sensitivity and specificity, but you should definitely perform some form of chest imaging looking for hilar lymphadenopathy, and then based on your suspicion, that might be as little as a chest X-ray, but consider high-resolution chest CT. So, what should you do? How do you approach these patients? Well, not every single one of them needs treatment. And in fact, a lot of these cases are in eyes that are at the end of their life, and further intervention may not be in their best interests. But what are you trying to improve? If there's some potential to improve their vision, then obviously that's an important consideration. Are they experiencing pain from rough ocular surface or recurrent epithelial defects, or is the cosmesis of considerable concern for them? And is there an alternative for treating that cosmetic concern, such as a cosmetic contact lens? So Shameen's already mentioned EDTA. It's a chelating agent which readily absorbs calcium, and you will, in most hospitals, be able to have this formulated for you in a 2 or 3% solution, which you can then use intraoperatively, as I'll show you in a moment. But if you're not in a hospital that can make that for you, you can make it yourself. You can just get some full blood count tubes which have EDTA in them, and if you get 4 of them and serially concentrate about 2.5 mils of normal saline and just shake it around and liberate and dissolve that EDTA, that'll work out to a concentration of about 2.5%. So here's a band keratopathy eye intraoperatively. You can do this just with some topical anaesthetic or block or some sedation, depending on the requirements of the patient. Remove the epithelium. There's lots of different ways to do this. You saw Shameen using a blade, and as in this image, but you can equally just remove the epithelium by rubbing it with a cotton tip. Often the epithelium is very loose overlying the area of band keratopathy and doesn't require an awful lot of effort to remove. You can use 100% alcohol placed on a well on the cornea and leave that there for 30 seconds and then wick it away and then wash it off, and then that will sometimes enhance the ability to remove the epithelium. I do think it's very important that you remove the epithelium. You can try doing EDTA chelation through an intact epithelium, but it'll just bore you to tears, so don't do that. If you want to get on with the job, you might as well remove the epithelium. And then you can just soak the EDTA on the cornea, and slowly over time it will chelate or draw out that calcium. You can just do that by lying a soaked wet cell on the surface, but I prefer to rub vigorously and frequently refresh the cotton tip I'm using with fresh EDTA so that I've got the maximum concentration. Beware, EDTA is slightly irritant to the limbal stem cell population, so I try not particularly carefully, but with some effort not to get it all over the limbus, and occasionally wash with BSS to make sure I'm keeping those cells as happy as possible. Here's just another example. So this one, you can see that defect in the center, and that's probably where they've had a more severe flake of the calcium flake off and leave this sort of little defect in the center. But again, the same principle applies. Remove the epithelium, rub on the EDTA with your preferred choice, and it'll generally come off. As you're doing that, you'll often find little flaky bits want to come off. I do try not to flick them off because you're going to increase the risk of causing irregular surface. A lot of these patients don't have much visual potential, but if they do, obviously if you're causing irregular astigmatism, that may impede their visual outcome. So try not to sort of pick at it. That having been said, they often do quite well once they re-epithelialize. Their topography normalizes as the epithelium fills in those little divots. And there are alternatives for treating that as well, such as laser PTK with an excimer laser. So there's been published papers showing that the outcomes from this form of approach are very, very good, with 98% of patients achieving good clearance of the visual axis. However, beware of recurrence. So recurrence rates vary wildly from as low as 5% right up to 30%, but you can pick those that are likely to recur. So if you're able to find a cause and treat that cause, then that will often reduce that rate of recurrence. And in those that have an untreatable cause or an unidentifiable cause, they're more likely to recur. Beware of the sick eye. As I said, if they've already got other ocular comorbidities, they're much more likely to have neurotrophism or limbal stem cell failure, and that significantly increases your risk of a persistent epithelial defect. So here's an eye with limbal stem cell failure. So you've just got to be a bit more careful, and I'm always careful not to traumatize the limbus as I'm removing the epithelium, but then also think, what else can I do to enhance the recovery of those limbal stem cells and therefore re-epithelialize the eye post-operatively? And so it's things like, do I need to put an amniotic membrane graft on? Do I need to close the eye with a tarsorrhaphy afterwards? And I would encourage the use of preservative-free post-operative topical agents to minimise the toxicity to the limbal stem cells. So in summary, I think EDTA chelation can be performed by all general ophthalmologists. If you're concerned and don't have a clear cause, it is reasonable to perform investigations. There are generally very good outcomes from EDTA chelation, but beware of the persistent epithelial defect and plan ahead, considering whether you might need to use alternative strategies to enhance the healing rate of these patients. Thanks.
Thank you. Whoops, gosh, thank you, Nick. So for those of you who don't know me, I'm Stephanie Watson. I'm head of the Corneal Research Group at the University of Sydney and head of the corneal unit at the Sydney Eye Hospital. And this talk is going to be about, look, what you do when you don't get a watertight wound. The talk is going to, first of all, I'll talk about corneal trauma. Then I'll address corneal repair, some different forms of it, concentrating on glue, and then look to the future. So corneal trauma is actually the second most common cause of corneal blindness. And if you have leaking full-thickness wounds from your trauma, you're at increased risk of infection. You can get hypotony maculopathy, and the patient also has a greater need for post-op care. So first of all, how do you know if you have a leak from trauma? Well, the warning signs is you've got reduced vision, shallow AC, hypotony, pupil peaked or altered in size, lens displaced or extruded. So if you see any of that, then you need to stop and put a shield on and proceed to further examination. Now, there are other causes of corneal perforations or leaks where you may need to get this watertight wound. But corneal trauma is probably one of the more common ones where it's difficult because the wounds aren't always regular. So you're sometimes having to bring together wound edges where you're missing pieces or they don't fit together well. But no matter what the cause of the perforation, the principles of repairing the cornea are the same, in that you want to restore the globe, restore normal anatomy, whilst minimising the risk of complications. The aim, firstly, to preserve the vision and then do best what you can, preserve the eye, sorry, and then do best what you can for vision. So we have a range of options when we have a wound that won't seal, and which one to choose depends on a number of factors, and you have to put all these factors together to make your decision. Firstly, it's looking at the laceration or the wound, what its size is, location and depth. Secondly, any associated features, foreign bodies. If there's an intraocular foreign body, you're going to have to go to theatre to get that out. Is the AC flat? Do you need to do something soon or can you wait? Is there iris, lens or vitreous involved? You're going to need more complex surgery. And then patient factors, whether the patient is actually fit for surgery, whether you can get them to the operating theatre, and then whether they can attend for follow-up. Because once you have glue on the eye, you have to see the patient again to manage that glue. And then lastly, available resources. Do you actually have glue? When I was in Vietnam, they had a trouble getting glue. They had a single little vial, which they accidentally spilt while I was there. But they used a lot of amniotic membrane because of that lack of access to glue. And how easily can you get corneal graft tissue? So first of all, if you have a small wound that's about 2 to 3 millimetres and no other structures involved, you can just trial a bandage contact lens without going to gluing. And you'll know fairly quickly whether this will work. If you seal off the wound with the lens, the AC should refill in about 20 minutes. You can leave them on in place for a month, but generally in these scenarios, you can take it off sooner. But always remember, if you have a lens and you give steroids, it's a huge risk for infection. So watch the patient closely. Now on to corneal gluing. Well, sealants are generally used for a wound 2 to 3 millimeters where the AC doesn't reform just with your bandage contact lens. Remember, cyanoacrylates can be potentially toxic, but they're generally more effective than fibrin. Fibrin has been tried, but it's hard to use in a wet environment, and it's usually only for small wounds. So what are cyanoacrylates? Well, this is the typical glue that we use to seal a wound, and they're esters of cyanoacrylic acid with alkali side chains, and they polymerize when they contact water or weak base. So when you have your leak and you put it on the eye, it'll polymerize. And look, they're available, they're generally low cost, and studies have shown in pigs and human that they can sustain pressures up to 100 millimeters of mercury. Another advantage of glue is once you have it on the eye, you've covered the stroma, and so it's said to inhibit further melting because it blocks the access of polymorpholeucolytes to the wound. And it can be antimicrobial, but not for Pseudomonas. It's active against mainly gram-positives, such as Staph aureus, Strep progenies, Strep pneumoniae, also some activity against E. coli and Enterococcus. So in some settings, you may have a perforation with a microbial keratitis, and in those settings, it can still be appropriate to use glue. It has some benefits over sutures in that it will induce less curvature change. So how do we go about it? Well, there's two methods. One of them is direct application, and another one is a patch. And with direct application, the patient has to be lying down. With the patch method, you can do that at the slit lamp. And when choosing between the two, you consider your range of factors in the decision-making of how to seal the wound. And one of those is size of the wound, size of the leak. And sometimes if it's a slightly bigger leak, you may find the patch method better. If the patient can't cooperate and lie down or can't cooperate with the slit lamp, then that'll also make the decision about which method you choose. You can, if you're in theatre, reform the AC first with air or viscoelastic. And this is particularly important if you've got a slightly bigger wound or you've got iris there, because you need to get the iris out of the way. So this is the patch method. So you need a bandage contact lens, you need your glue, and you need a small punch to cut circular pieces from a bit of sterile plastic, and that's typically some surgical drape. You then use chloramphenicol ointment or KY jelly, and you put it on the tip of a cotton bud. You pick up one of these little circles that you've cut out. You then put the glue on the top of this circle. Now, when you're using glue, it's best to draw it up with an insulin syringe because a very tiny amount goes a long way. And often I don't even use a full droplet of it. It's almost half a droplet of it that comes out. And then at the slit lamp, you can then place this directly on the patient's eye. You can place more than one patch if you need, if that first patch hasn't worked. Here's an example of 2 patches. And lastly, you put a bandage contact lens on. If you're doing the direct method, the patient just lies down. You'll need a speculum. You'll dry the area. And then again, you'll drop the most tiny amount that you can possibly get from that tip of that insulin syringe just directly onto the cornea, and it'll spread out like a sort of a volcanic, like a volcano, and then you put your bandage contact lens after it's dried. But what do we expect once we've done the glue? Well, the most important thing is that it's actually just a temporizing procedure. So it buys you time because you're going to have to generally do something else. It's very effective at day 1. You'll be cytol negative in about 90% of cases, but about a third of patients, they'll need to be re-glued, or you may need to perform a definitive procedure, and that could include corneal grafting, lamellar grafting, or even evisceration. You can wait for the glue to fall off, and generally it will fall off once it's sort of epithelialized underneath. But we've reported cases where the glue has stayed for a very long time. This was a lady where the glue stayed for 5 years and 3 months. So, and once the glue's there and you have the contact lens, the patient has to return for a visit to get that contact lens changed at least monthly. and there's risks of vascularization. It doesn't biodegrade, so it has to fall off, and it can be locally toxic due to the degradation products. It can incite acute and chronic inflammation, and it needs to be removed if it's there for too long. Now, if you do need to remove it, you have to bear in mind that you may then need to, if there's a big leak, you may need to re-glue or proceed to lamellar corneal grafting or penetrating corneal grafting or do something more definitive. So corneal glue for repair is mainly a temporizing procedure. Over half of the patients still require something more definitive to be done. So after you've glued, you need to monitor the patients closely. And this is why generally it's best to have a plan about what you're going to do next. In some cases, though, it can be the sole treatment. It falls off and it's all healed underneath, or you remove it and it's all healed. But it can remain in situ for years. Let's check the time. Oh, coming out of time. So when glue doesn't work, you need to suture. And with this, you do some deep sutures that can compress the tissues. Now, the point that I wanted to make here is if it's still leaking after suturing, you can glue on top of the suture or glue to the side of the suture wherever the leak is coming out. Conjunctival flaps have been tried, but they're a bit difficult to do on a soft eye. So another way to seal a leaking wound is actually a Tenon's patch. And here you just take a small piece of Tenon's from under the conjunctiva and you stitch it onto the front of the cornea where the leak is. And this might be something you might do if glue is not available or other means of sealing the eye. Amniotic membrane can also be done, but again, it's a little bit tricky on a soft eye, and you generally have to do a multi-layered approach. For corneal grafting, you've got patch grafts, you've got full thickness grafts. And generally the lamellar grafts you'll do when you can't glue, when the defect's above 3 millimeters and you've lost some corneal tissue and the anterior chamber's flat. Penetrating keratoplasty just reserved for large lacerations with significant tissue loss, but particularly in children, they're not a good idea because it's hard to manage the irregular astigmatism. One thing we've been trialling lately is actually using an endothelial graft to try to seal a corneal wound. And this can be done, but is a little bit tricky on a soft eye and may not give you enough tissue replacement, particularly if you have a melting condition. So for the future, we need better sealants, we need artificial corneas, and we need knowledge. We currently have a registry that's collecting data on trauma around the globe, and if you're interested in joining, this is the information here. So getting a watertight wound. Look, it can be a cause of visual loss if you have an ongoing leak. Remember to watch for infection and consider prophylactic antibiotics. There's a range of ways to close a wound. You need to consider not just the wound, but also the patient factors. And we need to understand the outcomes in the long term. Thank you. And you can follow me on Twitter. And now, while I'm here, I'd like to introduce Jacqueline Belts. She's a corneal and cataract surgeon from Melbourne.
Thank you. Thanks very much for having me. I'm talking about cataract surgery in patients with corneal disease, but specifically with a short amount of time, I've chosen keratoconus because this is an area that has really progressed since we last had this opportunity to meet face-to-face at Ransco. So cataract surgery in patients with keratoconus. These are my financial disclosures. Usually when we speak about challenging cases, we speak about all of these points, but today I'm going to mostly speak about IOL selection and calculation because this is where the real advancement has been. But I will mention forward planning because this is so important with any more challenging case. And in terms of keratoconus, it is important to make sure that the keratoconus isn't progressing and that actually is the cataract that's causing the visual significance. Look, in the cataract age group, it usually is the cataract, but worth keeping in mind, especially because if the patient does need an additional procedure such as cross-linking, the timing and sequence should be considered. Also, if the patient's likely to be a candidate for corneal transplant, the sequence should be considered because sometimes this can be done as a combined procedure or my preference, which is staged with transplant first. Now, In terms of keratoconus, patients do get cataract at a younger age. And the thing is that these patients are often myopic, and the myopia is often highly asymmetric, with usually irregular astigmatism. The axis is often oblique and non-complementary, and all of these patients have increased higher order aberrations, even in subclinical or very mild cases of keratoconus. So these things are important to remember. We have different lenses available to us, obviously, and in terms of keratoconus, we can choose a monofocal lens, whether it's toric or non-toric, and I'll go into that in a small detail in a moment. Small aperture is another option that we have to decrease the impact of highly irregular corneas. I won't speak about that too much, but remember to make sure the central cornea is clear without opacity. And in terms of keratoconus, the small aperture lens works best with an inferior cone, particularly infranasal or infratemporal. So not such a good choice when the cone's central. I've put presbyopia correcting lenses in brackets because I don't recommend those for keratoconus. There are some good cases out there with excellent results, but in general, these aberrated corneas are not a great match for presbyopia correction. Now, when to use a toric is probably the most common question that I'm asked about keratoconus, and there's a few specific rules, although there is still an art to choosing toric versus non-toric for some of these patients. I would say the most important thing to consider is that to improve a patient's astigmatism with a toric lens, they need to have a regular component to their astigmatism. We're only addressing the regular component with the toric lens. So really these patients have good spectacle-corrected visual acuity before they got the cataract. It's quite important to not insert a toric lens to a patient with keratoconus who's reliant on RGP lenses, because that's not a good match with the RGP. The RGP will bring out the lenticular astigmatism that we've put in with the toric lens and make it very difficult and expensive to fit a hard contact lens afterwards. So don't use a toric lens for patients that need RGPs. Of course, the keratoconus also needs to be stable. Now, lens calculation in patients with keratoconus is less accurate. About 40% of eyes with keratoconus end up within half a diopter, and this contrasts to normal published results in eyes without keratoconus of more like 80%. And there's a few reasons for this. Firstly, the normal biometric assumptions just don't really apply in terms of keratoconus. And one reason for that is that the standard ratio, presumed ratio of the anterior to the posterior cornea just doesn't apply in keratoconus, kind of similar to how it doesn't apply normally in post-refractive eyes. Also, the measured keratometry values are not necessarily equal to the keratometry values on the visual axis with keratoconus, and measurement errors do occur and they're not uniform across the cornea. Also, the corneal curvature is not consistent along any given meridian. So this creates particular challenge with the normal assumptions in normal IOL formulae. Also, with keratoconus, we have a deep anterior chamber. The effective lens position is difficult to estimate, and the long axial length and the steep Ks also add further uncertainty to the IOL prediction. And this all adds up to leading to hyperopic outcomes that we know can occur with keratoconus. Now, I mentioned that there's been significant advancements, and the last few years has really seen the emergence of this whole new category of IOL formula, which is formulae with modification for patients with keratoconus. There's a Holiday formula, a Kane formula, and a Barrett formula, and they all aim to improve outcomes for these patients. Of the standard formula, the SRKT has traditionally and in the literature been shown to be probably the best formula of those older generation formulae, but that's not for a specific reason. It's really just because the SRKT resulted in a lot of myopic surprises, especially as the axial length became longer. In fact, the Barrett Universal 2 as a standard formula also has quite good results for different reasons there. But now we also have the Holiday keratoconus formula, the Kane keratoconus formula, and the Barrett True K keratoconus formulae. And these have all been modified in different ways by the authors to take into account the differences in eyes with keratoconus. So to speak about them a little separately, the Kane keratoconus formula is available for free online at the website shown here, and was published by Kane and his colleagues in ophthalmology in 2020. And what they did is a retrospective chart review, taking into account 147 patients of 5 different surgeons, 1 eye of each patient. And they looked at the prediction error for different formulae. And it is worth noting that they separated the outcomes according to the stage of keratoconus, but this analysis was done prior to the availability of the Barrett True K keratoconus formula. The results of this study of the Kane study showed that the Kane formula for that data set achieved the lowest mean absolute error and the lowest median absolute error, and the highest percentage of eyes being about 50% falling within 0.5 diopters of target across all of the different stages. And you can have a look in the actual paper for the results of listed according to mild, moderate and severe keratoconus. Graham Barrett has modified his True K formula to include a modification for keratoconus, and this was published in JCRS in 2021. And again, this formula is available for free online at the website listed there. In the Barrett paper, he performed a retrospective chart review of 32 eyes of 23 patients. Quite a number of these patients did receive toric intraocular lenses, and he found that the keratoconus-specific formulae showed improvement, but in particular, the highest percentage of eyes within plus or minus half a diopter was the Barrett True K keratoconus measurement. And it's important to note that there are 2 options with the True K keratoconus formulae. You can use measured posterior cornea or a predicted posterior cornea. And the best results from the Barrett paper were achieved with measured posterior cornea. So we've had a lot of talk over the last few years about the fairly new ability that we have to measure posterior cornea in a lot of different ways. And so far, for most indications, the predicted posterior cornea that is taken into account in many of the newer generation formulae has been more successful than measured. But this is one of the first times that we've seen better results if we do use the measured posterior cornea. And it can be measured by a number of different instruments. The 2 options that we have when we're using the Barrett True K keratoconus formulae are to use Pentacam or IOL Master. And I thought that I would show you just briefly how to use those measurements. So we'll just run through quickly. So of course, just go to the website. I use APA CRS and choose the formula. Make sure you choose the True K formula for prior LASIK, PRK, etc., keratoconus. Choose the keratoconus modification and fill out all the data. Now, it's not until you actually hit calculate that you get the option to choose measured or predicted posterior cornea. And if you do choose measured, it's important to select which instrument you're using to measure the posterior cornea, because it does cause a difference in the formula. So if you're choosing IOL Master, choose IOL Master keratoconus. If you're choosing Pentacam, choose Pentacam keratoconus. And the calculation can then occur, but I find it interesting that you can also go back to patient data and see what your answer would have been if you'd used the predicted posterior cornea. So that's also good to do. Now, where to find the actual measurements for posterior cornea? This example is from Pentacam, and I can't get the pointer to work, but most of the maps that you print out of the Pentacam will have the section for the back surface of the cornea, and you can choose to use radius or keratometry data, but if you do choose the posterior cornea keratometry values, that's a negative value, but when you enter it into the formula, you can just omit the minus sign. Now, if you want to use IOL master for posterior cornea, I'm sorry I don't have an example listed, but you do need to be aware that this is not the TK value, it's not the total keratometry, it's the PK value, which is posterior keratometry. And you need to configure your IOL master to show that on your printout data page for the corneal data. So it comes up as PK1 and PK2. Again, that will have a negative sign, but you can just omit the negative sign. And I'm happy to show anybody where to find those numbers if you need clarification. Now, how do we take care or predict the amount of hyperopic surprise, or are we even still going to get hyperopic surprise? This is quite a controversial area now. It hasn't been in the past. We've all been taught to aim myopic, increasing amounts with increasing severity of keratoconus. And these targets that I have are from the Kane paper, and I am using myopic targets fairly similar to this. And the keratometry reading here, according to the stage, is the steepest K value. So for mild keratoconus, we probably don't need to use an adjustment. But for moderate and more severe, I still use a myopic target. I know that Graham Barrett, with those excellent results in his paper, is definitely aiming closer to emetropia. And I think this is the area, well, this is the slide that I really look forward to updating over the next year or so as we have more data and we can figure out really when to apply the keratoconus formulae and whether we need to aim myopic or not. So we still really need a bit more data in relation to these newer generation formulae, especially in relation to what degree of keratoconus we should start using them and refining the targets, as I mentioned. But I truly think that things are looking much better for patients with cataract and keratoconus, thanks to these newer generation formulae, and the results really improving, and I look forward to seeing further improvement over the next few years. Thank you.
Thank you for presenting a difficult topic very clearly. So I now have the pleasure of introducing Drs. Svetlana Sharampov, who is at St Vincent's Hospital and leads the translational program for ocular pathology there. She's appointed at the Notre Dame University and UNSW for her academic positions. And she's going to be talking on corneal pathology, when to send a specimen and how.
Thank you so much for inviting me, Stephanie. So my disclosures, I'm a salaried medical officer at St Vincent's in Sydney and a salaried academic at Notre Dame and a conjoint at UNSW, and I have no conflicts of interest. So I thought for this audience, we might just look at some of the more common presentations you might deal with and how to manage some of those samples that you might be thinking of sending to pathology. So in the non-neoplastic group, we've got infection, immune-mediated, and the dry eye limbal stem cell disease group. And in the neoplastic, we've got the epithelial, the melanocytic, and the lymphoid. So with infection, for bacteria, it's best to just send it for culture and sensitivity. You'll want to know how to treat it and what it's sensitive to. For viruses, fungi, and mycobacteria, the most sensitive test is actually PCR. You'll actually get the species from that as well. But for acanthamoeba, it's still a scrape and a Giemsa, so a direct smear on a slide. So that's infection in a nutshell. The immune-mediated diseases, all of you are aware of OCP or mucous membrane pemphigoid, but just to be aware that all the other autoimmune blistering diseases that involve skin and other mucosal surfaces can also involve conjunctiva. So this requires an incisional biopsy of the involved area, and you want to make sure there's a bit of intact epithelium in there because we're looking at immune complex deposition in immunofluorescence. So you want one that's fresh and you wrap it in some saline-soaked gauze to keep it nice and moist. So it doesn't dry out in transit, and the other piece goes in formalin. So bear in mind though, up to 60% in the reported literature can be negative on immunofluorescence. So you want to treat that empirically and then do a review, because if it's involving conjunctiva, it's likely involving another mucosal surface. Have a look in the mouth. Biopsies from there just have far fewer risks in terms of cicatrization. There's a lot more tissue to work with. You can do repeat biopsies and progress biopsies. So we don't recommend that our surgeons go back and keep biopsying the conjunctiva. And just to show you what that looks like, so I just wanted to show you two different diseases. There's mucous membrane pemphigoid on the left and epidermolysis bullosa acquisita, very rare. But we always correlate what we see on histology in terms of where the blistering's occurring, what cells are in the blister and around it, and then look at where the immune deposition's happening on direct immunofluorescence. So you've got to correlate the two. And it has to go with clinical history. These can be really similar. And here are some other ones. So we've got pemphigus vulgaris, paraneoplastic pemphigoid, and bullous pemphigoid. So it's really always a clinico-pathological diagnosis. You want to make sure it's in the right clinical context. You've looked at the patient and thought about other potential sites of involvement. Perhaps there are other laboratory tests like serology. We always have to correlate the histology with the immunofluorescence and then talk to you to come to a diagnosis. And every single pattern that I've just shown you can actually happen in a drug-related blistering disease. So it's really important to have a good history and good communication. These spectrum of dry eye disease and limbal stem cell deficiency, as you all know, are multiple causes and dynamic processes. You usually know the answer from the clinical tests that you do, from epithelial integrity, tear film, staining the surface, confocal microscopy. So you often don't need us to give you much. But if some people prefer to do some impression cytology, and it's very much clinician dependent, if you are going to do that, the technique can be quite difficult. So you can either just put the filter paper directly on the surface with forceps, or there are little devices that actually hold it on for you. You've got to mark the surface that you're collecting the cells on, and then you need to apply for 10 to 20 seconds to make sure you get a good sample. You want to keep the eyelids away, keep the tears away. So you've got to have a quite compliant patient. And we basically fix that. We make sure that the right side with the sample on it is facing up, and we will stain it, and then we'll try and dissolve the filter paper away with some xylene. So if you go on times 100 and you use oil immersion, you can get beautiful, beautiful images like this publication here. So you can look for whether the goblet cells are there, whether there's squamous metaplasia and keratinization, whether there's epithelial atypia, dysmorphia, and also goblet cells. And then you can look for, and you can also do neutrophils in that context as well. But this is what it actually looks like. So the filter paper never really goes away. I think that's a ×5 objective, that's higher power, and that's higher still. And this ophthalmologist did a great job because they collected a lot of tissue, right? But then it's quite hard to see through it. And if you're going to do this, then you really need to be talking to your pathologist and working this protocol up, because they'll be spending a lot of time on times 100, which most people don't like to do. You want to know what criteria you'll be reporting, and you want it to be correlated directly to what's happening in the patient. So maybe it's good in terms of looking at progress or response to therapy, but you really do need that clinicopath correlation, and your pathologist will need to want to get up and train, and because the grading systems are quite complex. So if we move now onto the neoplasias, in the epithelial arena, you all know the concept of OSSN, but that's actually a clinical descriptor. It's an umbrella that covers a number of histological appearances. So that could be intraepithelial neoplasia, which has 3 grades. It could be a papilloma, which might or might not have dysplasia in it, or it could be a carcinoma in situ, or an invasive carcinoma, and they can be squamous or non-squamous. So how do you deal with this? Well, we always like to have an excisional biopsy because then we can tell you everything. We can tell you what's happening in the epithelium, whether it's involving stroma, we can give you a margin status. But if you are going to do it, there are some of my practitioners who do incisional biopsies, so they get a tissue diagnosis and they treat topically, and then they do progress incisional biopsies. And it might also be good in the context of mapping. But when you've got extensive or multifocal involvement, that might be the time to refer to the ocular oncology people. Impression cytology is a little bit, can be difficult because it requires that you have a pathologist that knows how to do this and has a lot of experience. So Penny McKelvey is probably the best person in Australia for this. The problem with it is that there's no sensitivity specificity studies, there's no published criteria. So you've really got to gauge whether it's appropriate in your particular setting. The next group is the melanocytic lesions. And so this PAM, again, like OSSN, is really a clinical descriptor and it encompasses a wide range of pathology. It could be anything from just extra melanin in the epithelial cells, so a hypermelanosis, or it could be an intraepithelial melanocytic hyperplasia, and there's different grades of that. It could be a melanoma in situ, or it could be an invasive melanoma. So the gold standard is always the excisional biopsy for these, and if you can do the no-touch double-freeze cryo, especially if it's a patient that's got a new or rapidly changing melanocytic lesion, that's the gold standard. It might, if you don't have access to that, again, it might be a good time to refer to ocular oncology. The incisional biopsy is not recommended for melanocytic lesions unless you're doing mapping biopsies to plan definitive surgery. So again, it's more of an ocular oncology setting. Going on now to the lymphoid, the most important thing that you want to take away is to manage a lymphoma, you need to know what type of lymphoma it is. So you need to immunophenotype it. So most of the ones that you'll see are either the mature B cell, and MALT or extranodal marginal zone is by far the most common. Then you've got follicular, which has 3 grades, and mantle. And then there are the diffuse large B cell lymphomas, and they can broadly be classified into 2 subtypes as well. So you can see if you're going to classify to WHO standards so that you can actually make a management decision about what next, you've got to immunophenotype. So we're very, very lucky in Australia. Most of our big hospital labs have flow cytometry. That's the best way to immunophenotype and demonstrate clonality. So that's your fresh sample. If there's going to be a transit delay, put it in culture medium. The flow lab will have that. So that's usually RPMI or Hanks. The formalin fixed tissue in the anatomical lab will immunophenotype that for you on the formalin fixed paraffin embedded by doing immunohistochemistry. So we get double immunophenotyping to make sure we're on the right track. And the most important thing is once you have that diagnosis, you need to stage the patient, so a hemato-oncology referral, to make sure, because about 30% will be extraocular disease, and that's a different stage. So they may need peripheral blood, MRI, PET-CT, potentially a bone marrow trophine. And this is a multidisciplinary management scenario, so both for diagnosis and in terms of treatment. So just a quick summary. Your fixed tissue is good for histology and cytology. It's good for immunohistochemistry. It's good for PCR and other molecular tests, which we'll come to. And your fresh sample is if you want a culture in the microlab and get your sensitivities. If you want to do immunofluorescence, you need to wrap that in some saline soaked gauze. And for flow, some culture medium. Okay, some people might be saying, oh, what about all those fancy molecular tests they keep banging on about? Have I got the right sample for that? And I think don't panic, because every single test I've listed up there, it's been optimised for formalin fixed, paraffin embedded. So if you just chucked it in formalin and sent it to the lab and went, oh, what about the molecular test? Don't worry, let the pathologist sort it out. They can absolutely do that with what you've sent. And finally, it's really important to strike up a good relationship with the people that you refer to, because it's a multidisciplinary effort to get the right diagnosis and the right management for our patients. So know what's available in your lab, who might be interested. There might be someone who's a real expert in lymphomas, someone else who's really a melanoma expert. Get to know them and consider doing a clinicopath correlation meeting once a month with them and your colleagues, or an MDT if it's a cancer management decision-making meeting. And always let them know what's coming. So I never knock a sample back, but I like to know that it's coming my way. And don't send your ophthalmologist a very rare and unexpected sample at 5 o'clock on a Friday. And finally, I want to thank Stephanie very much for inviting me, and all the fantastic people at St Vincent Sydney, both in the laboratory and my pathology colleagues, the ocular oncology MVT colleagues, and some of those are fellows of your college, and my research group. Thank you.
Thank you. Okay, I'd like to open up for questions now. I've finally figured out how to use the live app. If anyone wants to put a question via here, I may actually be able to see it. And there's also some microphones in the room. It's very hard to see from here.
Can I ask a quick question whilst we're waiting for one?
Yes, please.
You mentioned in your talk, gluing a traumatic defect and then potentially sometimes gluing on top of sutures. Are there any tips about that? I've just seen a couple of instances where some haphazard sutures have been put in and then histoacryl glue put on top, and then they've all become incorporated, and then you can never undo that. So I think, there are some ways to do that better than others.
Yeah, I think the thing with glue is to not use too much, and and if you've got a wide wound gap and your sutures aren't in properly, then yes, it can go down into the wound gap. So it's sort of more just a thing. If you sometimes with the sutures, you're sort of placing them and you're putting more and more sutures in, and then you're actually creating problems because you create more holes through the wound, and then you're sort of getting more leaking. So it's sort of a get yourself out of trouble thing. And so sometimes it may not even be, on the wound. It may be, on the area where you've created lots of holes from your sutures.
Less is more.
Less is more. That's right. Less is more. The tiniest bit. Anyone else want to comment?
I think when you're using glue in the context of sutures, you need to make sure that your sutures have done a good job, and they do need to be a little bit on the tight side because your tissue's swollen. And then when you're using glue, it really only should be for a tiny, tiny leak that you're worried about. If it's really fast flowing, you are not going to win that battle. You'll get glue everywhere, and I've made that mistake before. Yep.
Thank you. Any other audience questions? Otherwise, yes, I have some questions. So, Tanya, if you could just sort of elaborate, rust rings, use of steroids, do it before removal of the rust ring, after, what's your sort of usual regime?
I actually don't use steroids at all in the management of rust rings. It's usually once you've treated and removed the inciting, it settles the inciting little nugget, it actually resolves itself quite quickly. So I don't use steroids in the context of rust ring removal at all.
I guess there's a risk, you're probably worried about the risk of infection.
Absolutely.
Yeah. So, I think we do have to be careful of steroids, particularly with the foreign bodies. Now, Shameen, PHSCD, is that just sort of like heaps of Salzmann's nodules?
It's thought to be slightly different. It was first described by John Dart's group back in, I think it's 7 years ago. And when they looked at the histology, it's slightly different. So it looks, for all intents and purposes, like just multiple Salzmannoid changes, but the histopathology apparently is slightly different.
So I guess these are the sort of things that you might get sent from an optometrist with query, is this OSSN? That's the sort of generally the most common context that I see, Salzmann's nodules and this type of peripheral generations in. So, what are the key features that would differentiate it from an OSSN?
The OSSN typically links to the conjunctiva. So there's something on the cornea and it kind of crosses the limbus into the conjunctiva. In an OSSN, there's also more vascularization, feeding blood vessels, leukoplakia. With the degenerations, many times there's a clear zone between the nodule and the limbus, And so there's that separation from the conjunctiva. Generally speaking, it's not vascularized and it looks scarred, or, yeah, for lack of a better word, scarred. So it just looks slightly different rather than a fleshy thing. The last thing is with most of these nodular changes, they're actually quite hard, whereas many OSSNs are soft and squishy. So differences.
That's good, that's good. And Svetlana, do you get sent many of these sort of degenerative things as query OSSNs?
I'm now just thinking back. I think there's a couple of recurrent ones, and I'm wondering if it's the intertissue means product. You've sent me quite a few Saltzman's nodules, Stephanie, from memory. So that's a really good tip. I'll go back and review those. It's a couple of cases I can think of that have recurrent, maybe different locations as well. So.
Okay.
And, yeah, I never knock a specimen back, as you know, Stephanie.
Yeah, that's right, that's right. So, Minor Miracle, we have a question on this app. Dr. Trin, could you please reiterate the bending of the needle and the scooping action you use to remove the rust ring?
Sure, so usually I'm just going to use my hand as a pseudo needle, but that's my bevel and that's my the arm of the needle. And I'll use a mosquitoes or something similar to that you've got in the clinic. And sometimes if I'm in a clinic situation where I don't have access to that, you can actually use the inside of the cap of the needle that it comes in. If you're using quite a small needle, the needle is quite soft. So if I'm using the cap that I'm putting in this way and you're getting it maybe 1 or 2 millimeters into the cap and they're using that force against the plastic to bend it, and your needle basically ends up like this. So it's almost like an ice cream scoop kind of shape. If you have only access to a larger needle, you do need to mitigate how much you're actually making a bend, because if it's too big, it's not actually that useful to you. So your needle almost ends up like this. And when you're scooping, the tip of the needle is not towards the cornea. So you're actually scooping it out towards you so that you've got nothing sharp going that way. Usually the knuckle of the bend of that bevel is enough for you to try and get some traction. And the only time where I'll usually use the tip is when you've got residual flakes around the periphery and I'm needing to chip away at that a little bit. And so I might just go chip, 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 and then I'll scoop, and then I'll chip, 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 and then I'll scoop again. So it is a little bit of back and forthing that you have to do with that sort of action. But the tip with the Clausic ointment and letting that marinate for 24 hours and getting that to come back will loosen up a lot of that tissue so that you're almost using a little bit of that lytic action to soften it up so it's easier for you to take out and you're not causing as much trauma. But you just obviously need to watch that you're not letting the patient comes back, obviously, and you've properly treated it.
Thank you. And Nick, what's the best way to avoid these tram lines? When you're trying to remove before you go in for your EDTA or during the process and you've got your blade and you're sort of working away there. How do you avoid getting those tram lines?
Well, I think as Shameen mentioned, you've got to be careful about the orientation of your blade. If you're using a blade against the cornea and you've got it angled into the cornea and you're moving ahead like a chisel, then you're going to dig in. So if you are using a blade, keep it at 90 degrees to the cornea and push across. I must admit, for most of my EDTA chelation, there's very rarely a blade involved. The epithelium comes off with a cotton tip, and then the EDTA application can be with a cotton tip. But certainly for superficial keratectomy cases where you do need to have a blade in there, then you've got to be a little careful and not moving too quickly and not with too much downward force.
I think that's probably a good tip. You can give lots of local anaesthetic drops before to facilitate, and then yes, just use a cotton bud. You always have to use a blade. And we have another question on the chat about Dermabond instead of histoacryl glue. No, I haven't tried it. It's a slightly different version of cyanoacrylate. It's slightly more toxic, I believe. Now we're going to Jackie. So, these patients are difficult because, you're sort of starting with an imperfect sort of eye, and then you're taking the cataract out, and they've got sort of expectations above and beyond, what they might be afterwards. Any tips sort of in counselling the patients and what you tell them?
Yes, so we don't want those expectations, essentially. And managing expectations, we all know that the best time to do that is pre-operatively. And I'm very careful about what I promise patients with keratoconus, and I'll often speak to them more than once preoperatively so that they really understand. I'll often explain to them that the way we choose a lens is by obviously taking a lot of measurements, but then applying estimations to those measurements to best predict the lens that will suit them. And I tell them that because their cornea isn't normal, those estimations are a lot more difficult. And I try to make them understand that we're trying to improve their vision, but I'll usually tell them that I'm expecting them to need glasses after surgery. The expectations in relation to contact lenses are really important as well. So if a patient is an RGP contact lens wearer and we expect them to still be an RGP contact lens wearer after cataract surgery, which is often the case if they have irregular astigmatism, that needs to be explained carefully and several times, because I find that patients can be disappointed even though it was always the expectation that they would need the contact lens. And if they are a hard contact lens wearer, we don't want to be, or optometrists don't want to be prescribing or fitting zero power contact lenses because they're very fragile and difficult for the patient to manage. So we really want them to have 2 or 3 diopters of myopia in those situations. So several discussions and clear expectations.
Yeah, no, I think that they're very important points. We have another chat question about topical steroids for central corneal scars after foreign body removal. I mean, some of these areas with topical steroids, there's no clear guidelines. We have to always balance up the risk between infection and this theoretical risk of reducing a central stromal scar. Usually, you know, if you've had an acute foreign body, you probably wouldn't go and give steroids straight away. You probably want to watch and make sure it healed and monitor for infection. And then, you know, monitor closely when you do. Svetlana, so, you know, sorry, oh, there's a real question? No, sorry?
There's a question. Yeah, sorry.
Oh, is there a question there?
Sorry,
It's impossible to see here with these lights
Sorry.
shining on us. Yes, please.
A quick one for Svetlana. You mentioned for acanthamoeba testing, cytology testing. What's the role of the acanthamoeba PCR swabs that we use? Can we trust them, or should we be sending other samples as well?
Do you have PCR for acanthamoeba where you are?
Yeah, the orange swabs.
That would be perfect. Yeah.
Thanks.
My understanding is that the more tissue you get on that PCR, the increased sensitivity. So it's not just a twizzle in the inferior fornix, it's a get some epithelium on that PCR swab.
You mean for acanthamoeba?
Yeah.
Yeah, so for cornea, they can be quite deep in the stroma, so biopsy or keratectomies are often better. Yeah.
If you're, just to finish that, or to build on your point, if you're going to take a sample for acanthamoeba and you're going to start treatment, you're going to be doing a bit of a superficial keratectomy anyway. You should send off that tissue as well so that your yield increases. I think that's what you were referring to, Nick. Yeah. So a lot of people just rub it on and then they'll send it off and then they'll do the superficial keratectomy. Don't just save all that tissue and send it off as well.
So, I mean, it's sort of, there's early and late acanthamoeba. If it's within the first 3 weeks, you've got a good chance of healing it quickly, and debriding the epithelium can actually really hasten resolution. And so if you have an early case of acanthamoeba, yes, you take off the epithelium and you send that off. I mean, when it's advanced and you're querying the diagnosis, that's where you might need to do a corneal biopsy. To make the diagnosis, because it can be then deeper within the stroma. Okay, and look, we'll finish up soon because it's been a long day. But Svetlana, pterygiums. Should we send you all our pterygiums?
Controversial. Look, it really depends on, so we actually treat our pterygiums very carefully, and I actually have a structured report for mine, so when Setmi sends one, it's a big report. There's a summary at the top, of course. I know you're short of time. But yeah, so you usually can be surprised. We've had a few between us, right? We've had an amelanotic melanoma. Someone else has sent me one that had adenosquamous carcinoma, which ended up metastasizing to a lymph node in the neck. So, I mean, it depends how comfortable you are I think pathologists don't tend to serve you guys very well because we're not trained in ophthalmic pathology. And so when you send, samples the other pathologists, they get a bit, balked by it. And so you often put a lot of your tissue in the bin, whereas in other surgical practices outside ophthalmology, that just doesn't happen. Everything that's part of a medical procedure, whether it's a fluid or a piece of tissue, goes to pathology. So we're always happy for that. We're always happy to develop protocols with you. And, Stephanie's a real lead in the registries. What if you had the structured data from a pathology sample to complement? That will be incredible annotation for registries and, to work out what's the spectrum of disease, presentations, management, prognosis. So I say yes, unless it doesn't, if you feel it's going to cost your patient extra. If you're in a public hospital, it costs nothing. You can always bulk bill the pathology. If you're in private, you just pop it in a jar of formalin and get your staff to call the couriers.
Yeah, no, I agree. I think if it's coming off the body, it's worthwhile putting in a pot. Yes, and just lastly, if when we're sending these samples, how do you prefer it? On a bit of filter paper? Do you prefer it with a stitch? Do you prefer it with a pen mark? What's the best way to?
So this is where you're thinking it's potentially a malignant process and you're doing an excisional biopsy. It depends. So Stephanie's always orientates her excisions with a notch, and so far we haven't had too many falling off. Some people like to do a suture. So if it's radial involvement by an intraepithelial disease and the margins are involved, the treatment is topical, so it doesn't really matter where the margin was involved. Topical chemo is the adjuvant. But if it's invasive and you may be going back to take some more out deeper, then perhaps where it is more important. So I think it's really up to you. You have the patient in front of you. You know best. Is it the corneal edge that you're most worried about? I know you can't take much off there. So it's I trust you guys.
Yeah, no, it really is a relationship between your pathologist, between the corneal surgeon and the pathologist. It's got to be, it's nice to have a good relationship. So thank you, everybody, for your time this afternoon and coming to our session. I'd like to personally thank all the speakers. I thought all the talks were excellent, and I learnt some things as well, and hope to see everyone tomorrow at the conference. Thank you.